anybody who's a radiology resident today, you have the capacity to be what I like to call a high performing radiologist. You can do so many things and you are so many things. So find your why, understand your why by understanding your values. And I like to call values our GPS. That's what gives you that direction. That's what allows you to follow your North Star. And for me, in the beginning, when I started, nobody was really talking about global health or talking about coaching or talking about some of the interests that I had. But I knew what was in me and I knew what my purpose and my value was. I think find out what that is, believe in it, stick to it, because there's a reason why you are that way. You are the answer to a certain solution. Just understand that.
Hello, everyone, and welcome to the Radiology Report podcast, where we are having conversations with the leaders transforming radiology today. You can find us on radiologyreportpodcast.com, Apple Podcasts, Spotify, Google, or wherever you get your podcasts. I'm your host, Daniel Arnold.
Welcome to another episode of the Radiology Report podcast. Today we are joined by Dr. Lilian Ebuoma. Dr. Ebuoma is a breast radiologist, U.S. Navy veteran, certified professional coach, and certified physician executive with over 2 decades of experience in health and wellness. As the founder of Lilly Women's Health and Lilly Cares Foundation in Lagos, Nigeria, she is dedicated to improving breast cancer outcomes in underserved areas. Dr. Ebuoma is also the author of Love Your Breasts, Love Yourself, a book that I have in front of me and have been leafing through and excited to dive into head first and talk through with you today. And is also the executive producer of Tufiakwa, Witnessing the Breast Cancer Journey in Nigeria. She was named top 50 most influential women in Nigeria by Business Day in 2023. Dr. Ebuoma, welcome to the show.
Thank you. Hi, Dan. Thank you for having me.
Absolutely. It's an absolute honor to have you on the show. I don't believe we've had anyone on the show doing the type of work that you're doing, building out imaging access in underserved areas abroad. So I am just beyond excited to learn from you today about the work that you're doing and the importance of it. But before we do, tell me about you. Where'd you grow up and how did you end up here in the US?
So I grew up in Lagos, Nigeria, and I came to the US about at age 18 and a half, almost 19. And shortly after coming to the US, maybe at about 6 months later, I joined the US Navy because, as an 18-year-old independent streak, I wanted to be, to do my own thing, to find my own way. And at that time, I just really loved the Navy's core values. You used to always hear honor, courage, and commitment. And I had this streak of independence. So I joined the military about 6 months after being in the US. So here I came from Lagos, Nigeria, nice hot weather, and I found myself in Great Lakes November of that year. I wanted an education, wanted to just understand more about life and to see where my life was going to take me. And if certain decisions, like for example, I wanted to be a doctor, if that was really what I wanted to be. So I joined as a hospital corpsman.
As a
So
hospital, what,
that's
sorry?
as a hospital corpsman, which is kind of like the LPN version of the military. So I joined as a medic, and in the Navy, it's called a hospital corpsman. So
Hospital corpsman. Okay, so I have so many questions. So, okay, were you a citizen when you immigrated to the
no, I
US?
was not a citizen, but I became a citizen 5 years later.
And how does that work? You can just show up and be like, "Hey, like I'm here and I want to be in the Navy." How do you even
No. So my family moved
yeah.
over. So my family migrated over to start living here, for better life, better opportunities. And then here I am, Mrs. Independence. I'm like, you know what? I think I'm going to join the Navy. Because I spoke to a recruiter and I liked what they were selling to serve the country,
Wow.
be all you can be. It just really resonated with me. I'm a firstborn. So I think I kind of have that streak of wanting to find my own
Well, I don't
way.
know. I have my oldest firstborn. Let's just say I don't think he's signing up for the Navy anytime soon. But so okay, so you go to the Navy. Where is this?
Say that again.
Where were you? Where were you stationed?
Oh, so here I am in Great Lakes in November. If you're top of your class, you get to pick the duty station. So they line up the duty stations, And whoever's first in their class, like academically, gets to go to the board and pick the duty station. So my mom is like, she's been talking to me like weeks before. Okay, I can't wait for you to come back home. She lived in San Diego at that time. So she's like, okay, where are you going to get stationed? Oh, I can't wait for you to at least stay stateside, or you have high opportunities to be in San Diego. Long story short, the day came for me to pick my duty station, and I walked straight up to the board and I picked Sigonella, Italy.
Amazing.
Picked Sigonella, Italy, and I was there for 2 years, and that's where I actually met my husband. And we're still married today. We've been married for over 21 years now. So met my husband in Italy, did my 2 year tour in the Mediterranean, which is a very nice experience. Then I was stationed at Naval Hospital Portsmouth in Virginia, attached to the weapons station there in Yorktown. So, and all through the Navy, I was always going to school. So I always went to school at night. So even though I was having this experience of, the military, um, being with other people, learning about other cultures, I would always prioritize my education. I really did want to be a doctor, and that kind of solidified it for me because I was a foreman. I was, used to work with the Marines, work with service members and their families. And I was sure that I wanted to be a doctor, and I had to get my degree. So I used to go to school at night. So I did a 5 year tour. And in that time, I said I had to, complete my bachelor's degree within that 1 year tour. So I did get that. And I was honorable discharge in 2001. So because everyone kind of knew I wanted to go to medical school, I wanted to be a doctor, they actually allowed me to process out because that was right after uh, September 11th.
Oh, wow.
So I was able to, process out. And then 2 years later, started University of Maryland School of Medicine. And so I continued to forge my path towards medicine and towards making a difference. And a big influence for me to want to be a doctor was my grandmother. I will always, I have to always, give her credit and tribute to her. She was a midwife. So she was a midwife, and I was the first grandchild. So I was always with her. I was always with her, kind of like, babysitting. So I saw her like as my mom, and they actually referred to me as her last born. So I was always with her, and she was, more than a midwife. Even in the neighborhoods, people would come to her for their blood pressure check, because that's how it was over there. You didn't really go to the doctors, or you couldn't really trust your doctor, or things just weren't readily available. So she was always this like local healthcare professional, so to speak, for the neighborhood, and always caring for people. So she was like a really, really big reason why I wanted to be a doctor. So I just had to kind of like, mention that was why medicine for me. And then when I got older, I wanted to make sure that it truly did resonate with who I was. And then the military helped me to solidify that.
Amazing. Amazing. So you find yourself in Maryland in med school, and were you gung ho about radiology right away?
Actually, no. I really, really wasn't. I'm a polymath. So I love to read. I love to study. Uh, I love to connect. I love to just be with people. And it was very hard for me. So I was one of those medical students that liked everything. When I got to family medicine, I'm like, this is awesome. This is what I want to be. When I was, through my internal medicine rotation, I loved cardiology. I loved internal medicine. I just found that I liked everything. So in trying to figure out what to choose as a specialty, contrary to a lot of people's desires, I ended up choosing radiology because I felt like it did allow me to touch every single specialty. It was what my perspective. I love technology. I love innovation. I like for things to just continue to get better. And I felt like radiology could provide me with that. And I think as a medical student, with radiology, you don't have a lot of exposure to it, but I felt like it could provide me what I wanted. And I was pleasantly surprised when I did start residency, that I was correct. And I did my residency at MGH, and the structure there was one that was very, you were always going to be facing patients, regardless of what you were. You just because you were on a chest rotation, you also did the procedures that came with chest. If you're on the abdominal rotation, you did the procedures there too. So you were always kind of exposed to patients, regardless of what rotation you were on. Then in my second year was when I got exposed to breast imaging. and I'd even been exposed to breast ever yet. And I ended up just really loving the fact that here we are talking about, what seems to be a small part of the body, but extremely important, in terms of, a woman's health, in terms of cancer, in terms of the impact, and then learning about the fact that here it is this one small part, but you could really go deep, deep into it in terms of advocacy, in terms of modalities. Like here I am now. When I started my focus year, that was when tomosynthesis got approved. So, the innovation, and now we're in contrast mammography, we've got ABAs, I mean, we've got breast CT. So I just really appreciated that it just continued to innovate and change. It could help with policy as well. So I was really drawn to that. And one of the things that also helped me to clinch it was I've always wanted to give back to my home country, Nigeria. And I was like, what would allow me to do that in radiology? Funny story. When I told my mom I was going to do radiology, on the phone, I'm like, Mom, I think I'm going to go into radiology. And she was like, no child of mine is going to be looking at pictures all day for a living. So I was like, so I had to school her on the fact that radiology is, we are the doctor's doctor, and there is so much more going on. So breast actually helped me to solidify that look, I can actually take breast radiology to Nigeria. But like a lot of people, I was like, well, do they even care about breast cancer? Is that even a big deal out there? Can I really make that impact? And that was when, towards the end of residency, I started to, look into what is happening in breast health in Nigeria, in low, middle, and income countries. Because I think, like a lot of people, you think it's just, infectious disease, right? It's just malaria, it's just TB. That's the biggest thing. But then I was surprised to find out about the growing rates of cancer, the lack of, infrastructure, lack of expertise. And I was like, you know what? This is great. So that was how I chose breast imaging, and I was very happy, and I have never regretted that choice.
So amazing. So where are you now? Tell me where you are today and what's your practice like?
So I am now in Cape Radiology. So I've moved from the Texas Medical Center. I was at Baylor College of Medicine for almost 7 years. I was an associate professor there. Then I went into a hybrid practice, which is like academic and private. And then I got recruited to join a private practice in southeastern Missouri. I'm in a place called Cape Girardeau, about 2 hours from St. Louis, which, you know, resonates with me because I love global health. And then when I got here, I realized that my practice is like the only like full-fledged radiology group, well, let's just say about a 70-mile radius. So
Oh,
we
wow.
actually cover Missouri, Kentucky, Illinois. And it was a little bit different from my usual practice, when I was in academia or that hybrid private practice, in that telemammography is a big part of our work because you have all these hospitals in rural areas
Mm.
where there is no radiology on site. So if you're not reading your screenings, if you're not doing their telediagnostics, these patients will have to, drive 1 to 2 hours to even get their screening or get their diagnostics. And a lot of them do have to come to the city to get their biopsy with us. So I really enjoy that because one of my big things is just providing access to care. I really strongly follow the mantra of all lives matter. And it shouldn't matter, your geographic location should not determine you getting access to quality care. So here I am in the United States and, practicing in a way whereby the similar barriers to care that I saw that I see in Lagos, Nigeria. I could see how in a place where we do have all of these systems, that there are some people, depending on where they live, they are also kind of distant from that care.
So, how is breast imaging different in the US than in Nigeria?
It is not for the weak. It is not for the weak. Extremely eye-opening, very humbling actually. So anytime I would travel to Nigeria and I'll come back, I never complain. I always remind my team that we are so blessed. and that we have everything that we need, and we just have to continue to make it work to serve the population. But just to give you an idea, for example, Lagos is like the major cosmopolitan city, and that's where I operate mostly out of in Nigeria. There's about 20 something million people, so the size of maybe Texas. They have, just to be very generous, like extremely generous, about 15 functional mammography units for that entire population.
Wow.
15, like 1 5 for
How
that
many
for
do you
that
think there are in
population.
Texas?
And
Let's see
that's
if we can
functional.
guess.
Yeah. And I think that's me being generous.
Yeah. I mean, there's
The
probably 1,500 in Texas, right?
It is about 1,500 in Texas.
Wow.
Exactly. So, the infrastructure is extremely limited. Expertise is extremely limited. A lot of things are siloed. So I think there was the paper I read as of 2015. Get this, there's about roughly 300 radiologists for the whole entire country of Nigeria, which is 200 million people.
Oh my
So for
gosh.
every one person, for every radiologist serves approximately 550,000 people.
My
That's
goodness.
that's that's what they're working. That's what we're working with in Nigeria. So it's very different. There's no population-based screening. The infrastructure is extremely disjointed to non-existent in certain settings. Then you also have like cultural issues as well. So you can imagine that because of that, then when you compare the mortality rates of breast cancer in the US, which is approximating over 90% survival, in Nigeria, it's over 60% to 70% mortality rate. So women are being diagnosed at stage 3, mostly stage 4. So a lot of times these women don't make it, or they have a bad quality of life. So what I wanted to do was see how could we change that narrative with what was already available. So my big goal was, how do we save women's lives in Nigeria with what we already have? Because a lot of people would have to actually engage in medical tourism, either to the UK if they have family who's there, or to the US. But when they get to the US or to the UK, they don't qualify for these healthcare services, or they'll have to pay out of pocket. Then a lot of people will also go to India. So you have many women who are going through one of the biggest stages of their lives in another country without family, without friends, and still expensive, even though it is in India. And then what about people who cannot even afford it, which is the majority of people? So I said, how can we use what we have that's already there in Nigeria, uh, and streamline that care? How do we streamline breast cancer care in a way that's multidisciplinary, starting with what we have already? So, because a lot of things are very siloed, right? You can imagine 300 radiologists, and most of them are not even experts in breast care. So, how do we even start to bring that to the population? And then culturally, there's a lot of stigma, a lot of misinformation. It's a bit of a paternalistic society as well. So if a
So
woman
yeah,
has
what are some of
paternalist,
those what are some of those stigmas?
so definitely, if you have a mastectomy, you're no longer seen as feminine. So women don't want to lose their breasts.
Mm,
If you have breast cancer, you can't tell anybody because some people are afraid it's contagious,
mm,
or they think that it's because you've done something. Something must have you've committed sin, you've committed evil. This is a curse. So women just don't come out because they feel like it's their fault, and then they may be treated as pariahs. So it wasn't uncommon for me, after giving a lecture, a woman would come to me in a corner, lift up her top, and her one breast is like the size of almost a basketball. And that's how she's been operating, because she's afraid to tell anybody that she
mm.
has this cancer, because it just changes her status. In some families, the husband's family may actually cast you out because of that. And then just a lot of misinformation. So if you do tell somebody, you get lots of opinions. Like, number one, the biggest one is, you would hear something like, there's a sign that they do. It's called tufiakwa. It's like a symbolism, which is why I named documentary Tufiakwa. So Tufiakwa means over my dead body. God forbid. That's what it means. So if you, it's like, God forbid. They don't want to hear it. It's not my portion. So then you tell somebody, they're like, yep, it's not my portion. So let's go to church, or let's go to a spiritual advisor. Let's pray it away. That's usually the let's pray it away. Let's cast it out, right? It's like it's a it's a bad sign. It's a bad omen. So let's pray it away. Start drinking this concussion that somebody would make. Eat lots of fruits and vegetables. Just lots of like opinions, which does what? It starts to delay detection. Then when it is detected, because a woman probably has Mets and she's not in a lot of pain, and they now propose therapy, the gallery comes back again. Oh, what is this chemotherapy that's going to make her hair fall out? I've heard this about this. So it's just, you know, it was just very difficult. And so I always say, like, those airline maps that shows the different locations that people travel to, the airlines travel to, those maps with the lines. This is breast cancer care in Nigeria.
Yeah.
Is the patient is just zigzagging from one place to another, from one place to another. Even if they find a good doctor, the family is very like, we don't think we like what this doctor is saying. Then they go to another doctor. So my goal was like, how do we streamline this? How do we not only educate, not only create awareness, but I found that the biggest thing that we needed to do was to navigate, which is kind of similar to the United States, right? The biggest thing was how do we navigate you with what we have, and bringing people, bringing together the different stakeholders, but in a way that was evidence-based, and without having to feel like you needed to lean on going to India. So I did a lot of collaborative work. It was huge, just collaborating, because as individually, even with my team, it wouldn't be sustainable. And then trying to get grants and trying to get funding. So we have community stakeholders in the religious leaders, in NGOs, community organizations. One of the strongest organizations that I partnered with was the community pharmacists, because the pharmacies there are used as a clinic. There are more pharmacies than there are hospitals. So it really is that like first line, anything that's wrong with you it's a very reactive society to healthcare, not preventive or proactive. So anything that's wrong,
Well,
when I
maybe
haven't,
maybe they have that in common with the US.
it's over time, over my journey, I got to realize that it really is the same everywhere. It really is in different formats. So I partnered with a lot of community pharmacists, and for them to help us with like opportunistic education, so to speak. So if somebody is asking about breast cancer, or they're having problems, refer them to our center. Then we're able to get, do the mammography if that's what they need. Find centers that also, you know, perform mammography. Find centers. There are two cancer centers that have now, private cancer centers in Lagos, Nigeria. One of them started in 2015, and the other was about 3 years ago. So things continue to change. So I partner with those organizations who can also administer treatment, because that was really big. And then also with the government has a nice social insurance program. It's just a lot of people are not aware, or they have other needs. So because it's a reactive society, but we did partner with the government organizations uh, to provide access through social insurance, to provide access to the population, so that we could do a lot of teaching and encouraging people who do have symptoms and concerns to show up and not feel stigmatized. So that's pretty much what the journey has been. Just a lot of navigating, collaborating, and kind of like building this like multidisciplinary framework, but it's different organizations. And so far so good. And a lot of teleconsulting as well. So I do a lot of teleconsulting, telemedicine, even before COVID happened, because that's kind of like how you have uh to do this. And then using the diaspora population. So surgeons and oncologists that are based in the UK and in the US, they all want to contribute, but they're not gonna just, pack up and go. So we were able to bring all of those entities together to streamline breast cancer care. And we demonstrated to patients in the Tufiakwa documentary.
Incredible. Well, thank you for sharing that context. I didn't know any of that. And so I learned a tremendous amount, as I think our listeners will too. And it's just, I take it for granted that all women, above a certain age are just going to go get their screening mammography, and that's how they're going to get diagnosed. And it sounds like even in Nigeria, if I understand you correctly, it's not even so much about setting up a robust screening program. It's even getting folks that have clear symptoms to go get seen. Do
Yes.
I understand that correctly?
That ended up being the big, because I think I was here in my own silo trying to start a screening program. But when I got there live, I realized, how about people who are actually symptomatic, people who are, and especially being, women of African descent, they do have a higher proportion of triple negatives and also having cancer at a
Mm.
premenopausal age. So you're having people who are like 30s and 40s with advanced cancers and with young children. So, and I always say this, and I don't like to say, I always say, unfortunately, the mortality rates for breast cancer is stated as 30,000. It could be more than that, because it's like breast cancer is cured with death, is what I say. It's like we don't really know the numbers because these women just die. These women just die, and we don't know what they're dying from. So, you know, that's the situation on ground. So it was how do we take care of people who are symptomatic? Let's actually, start there and navigate and help them to follow up, because it is about that early detection and early treatment. And those two things were not happening. And the mortality rate was just abysmal for no reason. And it just broke my heart. And like you said, it humbles you, with what we have. And it breaks my heart that something that's treatable, for which a woman does not have to die, and it's an unnecessary death. And that's kind of like what really propels me to try to make a difference.
How long have you been working on this?
So I've been working on this since 2018 officially. Always been on my mind. I did a feasibility study, trying to understand, do they even care? Because like I said, most people just think it's about malaria, it's about TB. And right about the time that I did start in around 2018, most companies in Nigeria didn't even use websites. It was information. Um, and people would say, I don't even think breast cancer is killing people, but there's a lot of stigma, so people don't talk about it. But they will listen if you show up. And that's what I found to be true. So we do a lot of community outreach. We've been everywhere. There's this particular community called Makoko. You might hear about it. It's the city of indigenous people in Lagos that live on the water.
Hmm.
We've actually gone there because we do have a mobile mammogram um, that, through partnerships with other entities, mammograms are sponsored for, and we kind of just go to these communities, to get them to get a mammogram. But it really is just to start having that conversation about breast health.
And how often do you go back?
You know, earlier on, I felt like I was going back every 2 months.
Oh
Yeah,
my
before
goodness.
COVID hit. Yeah, well, before, and I have young kids, but before COVID hit, it felt like I was always going back every 2 months just to set things up, because it's nothing. And what you do see too is a lot of having to, because of the lack of expertise, you're the only one in the room that knows what things are supposed to look like.
Yeah.
That's what it was. Because so then having to bring together a team and upskilling, you had to really upscale the personnel that you did have. So, you get somebody who has no idea about medicine, but they're interested and passionate about learning, and you would make them, a health educator by, you know, teaching them the basics, uh, educating them on what breast health is so that they could go out into the community. So we have an army of people who volunteer to do that. Then your technologists, they call them radiographers. They don't like the word technologists over there. They barely do mammograms. you
Mm,
know. So I had to really start to teach them about positioning, about the BIRADS system, which
yeah.
they loved. You know, they didn't even know how to label ultrasounds, you
Mm,
know, but I had to teach them about how to label mammograms, how to perform ultrasounds and how to label ultrasounds in the right way so that we could take advantage of teleconsultation, you know, how to do sweeps and things like how to speak with patients, what certain things mean, using scar markers and mole markers, you know, different things like that, and how to do a proper questionnaire for for a patient's breast health intake, what all those things mean. So it was really starting from ground zero.
wow. Well, it sounds like the teaching that you've been doing in Nigeria doesn't stop in Nigeria. You have a passion for um, elevating others. Talk to me a little bit about coaching and how you found that and what you're focused on there.
So coaching for me, I feel like coaching actually, I always say it saved my career. It saved my it saved me as a person. Um, so in general, the definition of coaching is take coaching, right? A coaching means carriage. So to take something or someone from point A to point B. So taking people, taking myself, taking organizations from where they are to where they want to be. And I think all of us strive for that, uh, to find purpose, to find meaning, to be a higher version of ourselves. So I'm a psychology major, so I think, and I love people. I love the human potential, you know, and I just believe that you should be all you can be, you know, if you can. So I was always drawn to that, like always searching, you know, reading this book, finding this course, finding that class, and people would always come to me like, "Tell us about your wisdom. You just seem to see things differently." I didn't really know it was coaching. So doing residency is about 2000 and I would say 7 or 8 is when I found out about this official idea of this entity called coaching. But I'm in residency. Doctors are not talking about coaching. Nobody, you know, it's too much of a soft skill, I guess. But I always liked it. And in 2018, I decided to get certified in it and really understand what is the mechanism of this coaching, how would it help? And that was around the same time we were talking about burnout in medicine. We started to talk about, you know, things like that. So the biggest thing that I feel like, you know, coaching has helped is help me to articulate that I'm okay. I'm not crazy. And that healthcare is truly a VUCA environment. You know, it is volatile, it is uncertain, complex, and ambiguous. Um, and instead of being, you know, disheartened or just feeling disenfranchised, how do I cultivate the skills that will allow me to be able to show up every day, to live with purpose, live with meaning, lead others with that because it does have a ripple effect, and just reinforcing that my medical career was not a mistake, you
Yeah.
know. So it really helped me to become a better decision maker, uh, critical thinker. I mean, it upped my game in emotional intelligence, which is
Yeah.
like the battle of
Well, and
every day.
it's not taught formally in medical school. Um in business school, I think we had a little more teaching about how to be resilient among situations that are often not going to have a right answer or not all outcomes are pretty terrible. And so how do you navigate
Yeah,
and be a leader through those tough situations? And you know, being a startup founder can be a quite lonely experience, and you basically go from being an A student who's getting F's all the time, and you're kind of banging your head against the wall,
yes,
right? And so there's a lot of parallels there, and I found in my own life mentoring others to be a way that gives me my own sense of personal strength, but then also helps develop that in others. So that resonates really deeply with me.
Yes, thank you for sharing that. And I really wish that we could start to infuse that more into medical education, because a lot of, especially those like those days, which is like every single day, what do you call upon? What do you call upon? And a lot of times I felt like just with the multiple components of emotional intelligence, that self-awareness is the key part,
Yeah.
self-awareness of myself, how I relate with others. And something I always teach my team too is, improve communication skills using that self-awareness, learning to really manage yourself. And one of the things that I find that works all the time, and a lot of people always come back to me and say, I use this thing, I keep using what you're saying, is reframing,
Yeah.
reframing, because of course, every day, so much is coming at you, and especially as physicians, everything kind of ends with you. Everything ends, starts with you. And it's just like, after a while, you kind of like go into this like survival mode and you just like, you know,
Yeah.
you feel like you're just like doing like, that Fruit Ninja game. Yeah. And that reframing just really always helps to allow me to just keep moving forward. And I really wish that we could um instill this more in education, and as well offer every level, early radiologists, mid-level, just start to offer coaching as a tool for you to learn more about yourself, like through personality inventory tools,
Yeah.
like the MBTI, Hogan assessment. So if you really don't understand yourself and how you're showing up and how others are perceiving you, it's going to be difficult. And I think you cannot help but burn out. It's a VUCA environment.
So what inspired you to write a book?
So, I think with just my career as a whole and my work in advocacy and what we've talked about, that everyone is essentially the same. And I realized there was a lot of fear. No matter, women are afraid. There's a lot of information. Sometimes it's too little. Sometimes it's too much, and just a lot of uncertainty. So I wanted to demystify breast health, demystify the process. And I wanted to write a book in a way that felt like I was speaking to a patient that came in for breast pain, that came in for a mass. You know, I always say, like, sometimes the women with a negative mammogram for pain are the hardest to convince that they're okay.
Mm.
So bringing those statistics, bringing an understanding of these are the most common diseases, this is how we treat them. This is what breast cancer is. This is what that journey looks like. And it is not hopeless. You know, some things are not perfect, but the goal is saving lives. So I wanted to create access to that information to all women, no matter where they live, no matter who they are. They get to have uh, access to education and health literacy.
And who's the book for? Is it for young women, older women, women concerned about their breast health? Like who are you hoping to reach?
I'm hoping to reach women, in the ages of 25 to 45. The book actually covers, 25 to, sorry, 55. The book actually covers, breast development. I talk about in the opening chapters the history of how we started to wear bras. How did that start out? And then talking about the meat, which is, breast diseases, talking about cancer. A surprising chapter for me that came because of my evolution as a breast radiologist was the survivorship chapter. In the beginning, we just talk about cancer, but then what happens after cancer? What does it mean to survive? I know there's some women who have, been cancer free for like 5 years, 10 years, but every time they come up for that annual mammogram, the fear is real. So there are other things that happen. So I have a survivorship chapter. And then I also have a nice section that there's a nice cookbook section of different foods that are uh, anti-inflammatory and pro health. So the book is really for really a wide range of women who are at different stages of their breast health.
Well, um, it's an incredible accomplishment. What did you think of the process of writing the book?
I'm gonna just tell it was intense. Like it was intense. I'm not gonna make it sound, at least for my first book, it was intense. it took me over 10 years. Like first draft was ready, like I think in 2013, but with family, full-time radiology work, uh, global health work, it took a long time. And I'm actually glad that it did because, like I said, I evolved. The person who launched the book is not the person who started the book. So that was helpful. And then also like dealing with like imposter syndrome. So then it's ready and you're like, am I ready to be out there? I think it's just now the physicians are getting comfortable with social media, being seen. So that was also a hurdle that I had to deal with to say it's one thing to write to publish in a journal, to your peers, and nobody really kind of knows about it except your peers. But it's another thing to put yourself out there as an author to the general public.
Well, you did it, and congratulations. And I encourage
Thank
everyone
you.
to pick up their copy on Amazon. I bought mine and it came 2 days later. So it can be on your doorstep very, very fast. What a world that we live in.
Yeah.
The ability to reach such a wide audience is very cool. So, you have such an inspiring story and such an interesting career. I guess a final question, a lot of the folks that listen to our podcast are residents and they're kind of trying to think about their own careers. What advice do you have for, the residents out there today?
No, I would say that um, just understand that anybody who is a physician today, anybody who is a radiology resident today, you have the capacity to be what I like to call a high performing radiologist. I think more than ever, you could do so many things and you are so many things. So find your why, understand your why by understanding your values. And I like to call values our GPS. That's what gives you that direction. That's what allows you to follow your North Star. And for me, in the beginning, when I started, nobody was really talking about global health or talking about coaching or talking about some of the interests that I had, because most people in academia at that time were just more about academic research. But I knew what was in me and I knew what my purpose and my value was. I think find out what that is, believe in it, stick to it because there's a reason why you are that way. And sometimes you are the answer. It's not sometimes you are the answer to a certain solution. Just understand that. Then start where you are with what you have. Do not despise humble beginnings. Don't try to be like somebody else. Be yourself. Start where you are, no matter where that is. Start where you are, step by step. And then collaborate with other people. Collaboration, like they say, collaboration is the new competition. And I don't know if you watched the Super Bowl this past weekend. I love what the Eagles coach kept saying. Your greatness is dependent on the greatness of others.
Hmm.
You
I didn't
know,
hear that.
oh,
That's
like
amazing.
I was just eating it up. I just loved it. Like, and
I
that
love
is the
that.
truth. That is the truth. That collaboration, you know, both above and below you,
Yeah.
is what's going to foster the progress and the change that you're trying to make. And just never give up on it. Never give up. It gets better. It gets better. Continue to believe in yourself. Follow your why. Don't give up. And just understand it. Everything is about transformation. So if you give yourself the chance, you're going to see yourself going from that caterpillar eventually to that butterfly. It's going to happen. It's really about evolution and just, give yourself grace and never give up.
Sage advice. Dr. Lilian Ebuoma, thank you so much for coming on the podcast.
Thank you so much, Dan, for having me. I've had a great time. Thank you.
You got it. And pick up your copy of Love Your Breasts, Love Yourself on Amazon today.
Thanks for listening to this episode of the Radiology Report podcast. Be sure to visit us at the radiologyreportpodcast.com or subscribe to the show wherever you get your podcasts to join us for our next episode. We are always looking for great guests. If you have someone you'd like to hear on the show, please get in touch with us online.